So my name is Steve Schauer. I'm an active duty lieutenant colonel in the U.S. Army. I'm currently a fellow in anesthesia critical care medicine at the University of Colorado School of Medicine. I'm a research fellow at the Center for Combat and Battlefield Research. I'm an associate professor at the Department of Military and Emergency Medicine at the Uniformed Services University. And I'm also director of the Alert Research Lab. So I've received multiple grants from the Department of Defense to my institution for unrelated efforts, not what I'm going to talk to you about today. No other conflicts report. And these views are my views and my views only and do not reflect that of the U.S. military or the U.S. government. So first and foremost, I want to talk to you about limb tourniquets. So prior to the recent conflicts, ATLS considered limb tourniquets to be a last resort. We learned during the first 2 years during the wars in Iraq and Afghanistan that extremity hemorrhage was one of the leading causes of potentially survivable death on a battlefield. Tourniquets have been developed and honed since that time. The technology is now easy to use and anybody can be trained to do it. It's now standard issue for every deploying service member. All deploying service members must receive formal training. They must be tested to ensure that they can adequately apply a tourniquet to a limb extremity injury. All deploying service members, Okay, we're going to start this slide over here. So first and foremost, I want to talk to you about limb tourniquets. Prior to the recent conflicts, ATLS considered limb tourniquets to be a last resort. We learned in the recent conflicts during the first 2 years in Iraq and Afghanistan that extremity hemorrhage was one of the leading causes of potentially survivable death in the battlefield. It is now a standard issue for every deploying service member. The tourniquet technology has improved and is now easy to use. All deploying service members must receive formal training and testing to ensure that they can accurately apply this device. There's large volumes of retrospective data and prospective observational data demonstrating mortality benefits. However, RCTs simply do not exist for ethical reasons, and we will likely not see RCTs. A recent systematic review demonstrated very large adoption of use in a civilian setting. However, high-quality civilian data is lacking for that exact reason I just outlined. Quick clot combat gauze. So topical hemostatic agents have existed for a while, but previous topical hemostatic agents that we were using prior to the recent conflicts had a problem. They would excessively heat up when they were exposed to blood, causing minor burns to some of the surrounding tissue. Quick clot changed that. Quick clot uses kaolin, which promotes coagulation by binding up the water within the blood, causing the natural clotting components to concentrate. Kaolin also activates factor VII. Both of these actions improve the hemostasis capability. It is now listed as the ideal topical hemostatic agent by the Committee on Tactical Combat Casualty Care, and is used as supported by many large animal high-quality studies and some limited prospective human studies. Again, RCTs are limited and simply not feasible. So balanced transfusions. Early in the recent conflicts, we were using ATLS-style resuscitation with crystalloid, where we administer crystalloid to determine whether they're a fluid responder. We later transitioned from crystalloid to Hextend. However, in a landmark paper by Colonel Matt Borgman in 2007, where he analyzed a balanced transfusion strategy of 1-to-1-to-1 ratios, they found that those that received a balanced transfusion strategy had a 19% short-term mortality versus those that were not receiving a balanced transfusion had a 65% short-term mortality risk. Balanced transfusions quickly became the standard practice in the military after that landmark study, and since that time have been adopted into the civilian trauma community. Civilian prospective data demonstrates benefit with the use of balanced transfusion strategies. However, there's been no civilian RCTs that have demonstrated benefit. There was one large RCT that was performed. However, it was limited by sample size and was noted to have a trend towards benefits. More importantly, I do want to point out that the only civilian RCT evaluating balanced transfusion strategies compared a 1-to-1-to-1 versus a 1-to-1-to-2 ratio. This is far, far different than a 1-to-1-to-1 versus the old school ATLS-style fluid responder method. So if we had had that comparison, we likely would have seen a much, much larger difference as opposed to 1-to-1-to-1 versus 1-to-1-to-2. So the military has pioneered the use of the emergency donor panel, oftentimes called the walking blood bank, also referred to as warm, fresh, whole blood. Retrospective data from early in the recent wars demonstrated that warm, fresh, whole blood was associated with a mortality benefit at 24 hours, 48 hours, and 30 days. It has the perfect balance of all transfusion components, and it's warm at normal physiologic temperature, and it's fresh. It's got full activity of all cell lines, and the clotting cascade is fully functional. There's reduced risk of hypothermia because we're transfusing it at physiologic temperatures. And there's growing development of the use of this in the civilian setting for things like mass casualty events and disaster events where the on-demand blood simply cannot meet the needs of the number of casualties that may come in. So next up is cold stored low titer whole blood. So the U.S. military has led the use of cold stored low titer whole blood, which we consider to be anybody with a ratio of less than 1 to 256 of anti-A and anti-B antibodies. A recent study we published up in the upper right there found that 302 trauma centers as of 2021 had documented use of cold stored low titer whole blood, and its use is growing. It's supported by substantial retrospective data and some limited prospective observational data. And I do want to point out that both the TOAR study and the MADIC study are randomized controlled trials that are underway evaluating the use of cold stored low titer whole blood for traumatic resuscitation. It's got significant logistical benefits, as it's got the ideal ratio of all the components all in one simple bag instead of 3 separate bags. It also has 1 single storage requirement. One thing to note is that it may lose some of its coagulation and platelet function after 14 days. This is now becoming more widely used in the pre-hospital setting, with San Antonio, where I was just stationed previously, being one of the leaders and early adopters of the use of cold stored low titer whole blood in the pre-hospital setting for resuscitation. Next are cold stored platelets. So current platelets have a limited shelf life when stored at room temperature. Room temperature platelets are often considered somewhat dirty and prone to infection, as the room temperature does allow for bacterial growth. Cold stored platelets, on the other hand, confer a shelf life benefit and potentially reduce the infection risks, and they're available for use up to 14 days. As previously mentioned, the platelet function of low titer whole blood declines after 2 weeks, so this represents a potential measure to help address that. There's limited retrospective data demonstrating similar outcomes when comparing recipients of room temperature platelets versus cold stored platelets, and there's currently a prospective randomized controlled trial underway comparing perioperative bleeding scores between those that receive room temperature stored platelets and cold stored platelets. It's called the CHIPS trial. Next up is the 4-step cricothyroidotomy. It's easy. Scalpel, finger, bougie, tube. 4 steps makes it nice and simple. It's significantly simplified the process of performing this procedure, which is oftentimes performed under very stressful conditions. Instead of using previous trach hooks and multiple steps for exposure, we've simplified it to 4 simple steps. In large animal models and cadaver studies, this has been found to be faster and more reliable than the old school method. While there's no prospective RCTs, the current data demonstrates this method is probably the best method and sort of the simplest. It has become the standard training method for U.S. military combat medics. It is now our training standard. Next up is the ISR rule of tens. So we were previously oftentimes taught to use the Parkland formula or the modified Brooke formula, which can be challenging to use as it requires an accurate measurement of TBSA, which is oftentimes hard in the field setting. It's even harder because this requires a calculator, because these calculations are not easy to necessarily do when you start factoring in all the data points that go in. We also know that excessive fluid intake can lead to bad things, namely pulmonary edema, abdominal compartment syndrome, all of which portend a poor outcome. The ISR rule of tens simplify that. It's easy. You estimate the burn surface area to the nearest 10%. If the patient weighs between 40 and 80 kilograms, you multiply the burn TBSA by 10, and that gives you your initial fluid rate per hour. If the patient weighs greater than 80 kilograms, for every 10 kilograms above, you simply increase the hourly rate by 100 milliliters per hour. Then you begin to titrate your fluid administration to urine output goal of 0.5 milliliters per kilogram per hour. Following that is the Burn Navigator. The system was developed by the U.S. Army Institute of Surgical Research and cleared by the FDA for use, and is now available on the market. This uses a mathematical algorithm that accounts for the last 3 urine output measurements, last crystalloid volume administered, TBSA, weight, elapsed time since burn, along with several other variables readily available within your EMR system. This is designed to be potentially incorporated into your EMR system, or it can be used as a standalone module for you to enter data points in, and it'll guide you on how much fluid to give. It's been commercialized by Acros Medical, and prospective observational studies have demonstrated that the use of the Burn Navigator is associated with decreased crystalloid volume administration and decreased incidence of burn shock. Next, we have the use of EnrouteECMO. So we've been doing transfers in VA and VV ECMO configurations across multiple continents for over a decade now. We've averaged 2 per year for the past decade, with over 50 transfers in total. The most common indication was post-trauma for people with acute lung injury secondary to blast lung. One study previously evaluated 40 activations, and they found that 4 of them died before transport arrived. 27 were transported, with 24 of the 27 surviving transports, so very high survival rates. and the remainder were found to no longer need ECMO upon arrival of the ECMO transport team, and the patients ultimately underwent standard CCAT transportation. Next up, we have Dialysis-Like Therapeutics. So this was an early DARPA-supported project, the Defense Advanced Research Project Agency, to create dialysis-like methods to filter out inflammatory cytokines, pathogens, and endotoxins. So it addresses the dysregulated immune response, most commonly within sepsis. Prospective randomized controlled trials demonstrate reductions in activated neutrophils, monocytes, and pro-inflammatory cytokines. This is still in early development with clinical trials underway, but intensivists are likely to see this in the future. Last but not least, we have the Tactical Combat Casualty Care Guidelines from the Committee on TCCC. This was first described by Frank Butler back in 1996. This was born out of the failures found from the Battle of Mogadishu. Medics at that time were taught primarily ATLS-style trauma, which is not necessarily applicable to military-type trauma. This has reversed the ABCs of trauma resuscitation into a CAB focus with an intense focus on hemorrhage control. The civilian version, the Tactical Emergency Casualty Care, was first described in the Journal of Special Operations Medicine in 2011, and is now the civilian standard for all tactical EMS programs. Additionally, much of the Stop the Bleed program traces its roots back to TCCC. Thank you for listening to my talk on military advancements now in civilian trauma care. I put my contact information up there. Please feel free to reach out to me with any questions or comments.